My name is Judith Hager. I'm a psychiatric mental health nurse practitioner student at the University of Texas, Rio Grande Valley. I'm presenting a case study regarding a mild neurocognitive disorder of vascular nature. The case study centers around a 76-year-old female named Betty D. The reason for Betty's appointment today is changes in behavior and mood. The history of Betty's present illness is sad mood, diminished interest in pleasurable activities, excessive worrying, difficulties in concentration and word finding, weight loss, insomnia, and agonizing ruminations. Betty states she stopped going to Senior Citizen Center because she feels insecure when interacting with others. She dropped out of weekly card game because she could not concentrate or memorize her cards. She reports the loss of 7 pounds in weight over the past 2 months and reports interruption in sleep with insomnia and ruminations about worry. Objective assessment reports disabled, low-energy 76-year-old female whose mood was depressed and anxious, affect sad. She's preoccupied with finances, temporarily reassured. She complained of forgetfulness. She has no prior psychiatric history. Her neurological exam was essentially non-contributory. She is a 15-year pack smoker. Betty has a history of hypertension, hyperlipidemia, coronary occlusion with an intervention step replacement, and tobacco use disorder. This visit, new diagnosis, major depressive disorder, mild neurocognitive disorder. Plan is to conduct a CT head scan, conduct a mini mental state examination, conduct a 4-item recall, a 1-minute list test, an alternating items list, clock drawing, and a Stroop test of response inhibition. Follow-up results of her CT shown pronounced periventricular and subcortical white matter hyperintensities. She scored 24 on her mini mental state exam. Of the 4-item recall, she was able to recall 2 of the 4 items in 3 minutes, a third when given several choices. On a 1-minute list, she named 14 items available in a supermarket. On the alternating items list, she was able to give 12 correct responses with 4 errors. On the clock drawing, she spaced the hours unequally, but the time was correct. And on the Stroop test, she had 22 correct responses over 1 minute. Her differential diagnosis is major depressive disorder, mild cognitive impairment, vascular dementia, early onset Alzheimer's dementia, and mixed vascular Alzheimer's dementia. Periventricular white matter hyperintensities are common with the aging process. However, subcortical white matter hyperintensities or deep white matter hyperintensities are vascular in nature and pathology, often associated with chronic cerebral hypoperfusion, hypertensive small vessel disease such as atherosclerosis. It is indicative of a higher likelihood of vascular dementia versus Alzheimer's dementia, often referred to as subcortical dementia. A CT scan or MRI is necessary for a positive diagnosis of vascular dementia as a result of the hyperintensities in the deep white matter. Literature suggests a cutoff point of 23, 24, or 24-25 for positive and negative results, respectively, for cognitive impairment and early dementia. Learning and memory tests, such as the 4-item recall, the 1-minute list, the alternative items list, tests of similarities in digital symbol substitution, do not hold up in dementia as aging progresses. Basic attention tests to detect dementia, such as the clock drawing, are used frequently in clinical setting. Executive function and information function tests, such as the Stroop test of response inhibition, where the score of less than 40 is considered low. Betty meets the DSM-5 criteria for both major depression and mild neurocognitive disorder of vascular origin, such as in vascular dementia. Contributing factors are Betty's age greater than 75 years, history of atherosclerosis, coronary artery disease, hypertension, which compromises vasoreactivity and hypoperfusion, and smoking that enhances blood viscosity, a key risk factor in vascular dementia. Vascular dementia is a progressive loss of memory with other cognitive functions by vascular disease. Both major depression and mild cognitive impairment are present in vascular dementia. Vascular dementia presents more prominently with problems of organization, attention, slow thinking, and problem solving. Deep subcortical white matter hyperintensities versus age-related periventricular white matter hyperintensities exist with vascular dementia diagnosis. Symptoms related to disruption of subcortical neural circuits that control executive function, affecting short-term memory, organization, mood, which presents as apathy, irritability, and depression, and psychomotor slowness. Second most common form of dementia is vascular dementia, second only to Alzheimer's type dementia. The prevalence increases with age. Early detection and preventative measures are especially important with vascular dementia. Lifestyle modifications such as smoking cessation, hypertension control with the use of ACE inhibitors and diuretics, which lower blood pressure without affecting cerebral blood flow, are important preventive measures. Physical activity and diets containing antioxidants, vitamin C, and fatty fish omegas are very important protective against vascular dementia. Pharmacological therapy should focus on medications with low anticholinergic activity. Drugs approved for Alzheimer's offer benefits for vascular dementia as well. Cholinesterase inhibitor donepezil and N-methyl D-aspartate receptor antagonist memantine can also help with vascular dementia to address symptoms of memory, thinking, language, judgment, and other thought processes. Anticoagulant, antiplatelets have also proven efficacy.